Hi, how are you?
Hello, Jessica. Riley, member of the information.
Oh,
And this is Sophie.
Sophie?
Yeah.
No.
Oh, not really. Okay.
I mean, I usually come in to just kind of get the...
Lay the land?
Yeah, thank you.
Yep.
Where's Dr. Fetter?
We're the kind of formal people, Dr. Fetter, diversity. So we're two different groups.
Okay.
Yeah. So next steps would essentially be Lupron. Lupron is a medication that, right, so essentially is like a medical menopause, really, is what we do. The nice thing about the medication is that it prevents any further growth of things like chest development that may be left to happen. It's also very reversible. So do you have any questions about that?
Well, I mean, it's just the usual kind of questions. Like, I'm always asking Dr. Fetter how it is that we determine these things.
Yeah.
So.
It's not like there's a test that we can do to say, yes, you have transgender and no, you're not. Going by the research that we do have, which I totally will put out there that it's not super long term, we base it on following the kids forward, knowing that in childhood that our sense of gender can kind of be very fluid. What we do know when we hit adolescence, incredibly rare for reversion to happen after. And it's also kind of helping the families to be supportive in that, yeah, if that rare circumstance happens and there is a reversion, that we're still going to be okay with that as well. If you decided to go on medication, there can be some irreversible changes that happen.
Right. So none of that really applies to my daughter's circumstances because it's a case of adolescent concept.
Yeah.
What you just described was a case of childhood.
Yeah, that's one case.
Dysphoria that was consistent throughout adolescence, but that was never the case in childhood or in early puberty, and so I think we're kind of comparing apples and oranges there.
Kind of, but also it's along the same spectrum, right? Everybody's going to be different in the spectrum. Some people it's at puberty, some people don't decide to go through.
What are the rates of reversion for adolescent onset dysphoria?
They're very rare. They're so rare you can't even count them.
Oh, really? Because I read like 90%.
Yes, I can't agree with that, for sure. And
well, what's the data on that? Can I see a study or something?
Sure. Yeah, I can get some papers.
Sure, yeah. I'd like to read that.
Yeah, absolutely. Usually 90%.
Oh, a couple of different studies.
Okay, I'd like to see those studies.
Sure, yeah.
Those out for me.
Yeah, do you have an email or something I can send them to?
Bring them in here.
Sure. Okay, yeah.
We can do a little transfer. Swap the studies. I'm totally down to do that. We can also get the data from this clinic if you want. We do know that there are studies that show rates of suicide, rates of depression, rates of anxiety when we don't support them and we don't kind of help them along the transition is incredibly high.
What about post-transition?
Rates are very good. Those studies, I can get those studies for you.
Sure. I've been reading different.
Again, like,
most of what I've been seeing is that there is no difference in the suicide rate post-op or that it is actually higher.
so what is the biggest concern?
Johns Hopkins actually stopped doing the transition surgery, that is.
They stopped doing transition surgery?
They did, yeah. I think they put it back on since then, but they stopped it for quite a while.
So what are your concerns?
My concerns is that no due diligence has been performed in the sense of confirming what the condition actually is. The idea that this might be a phase that's never on the table to begin with. From the time that I found out that she'd actually been referred here without my knowledge, everything has been in pursuit of an actual transition without ever actually considering any more conservative options. It was always the case that I was supposed to support the transition, but I need to have some kind of an assurance that this is going to mitigate harm instead of inducing future harm before I can support about it. And I haven't seen anything in the way of any due diligence or any consideration of any more conservative options.
So what would be your suggestion for a confirmation?
Well, I mean, how would you confirm something like that? Dr. Fetter would say, some people are born with XXY chromosomes, and well, okay, as a child been tested for Klinefelters, and he would say no. And he would say that, some people are born with a brain that is more anatomically male or that is female. And I said, well, has an MRI been done to confirm that my child's anatomy, the brain anatomy, is more congruent with that of a male than it is of a female? He would say no. I would say, well, are you going to refer for an MRI? And he would say no. So it seems to me think that everything that's sort of driving this is really more ideological and activist-based than there is any science to support it.
But as well as if we're going based on science, right? There's no science that backs up that if we do an MRI that it's going to change anything with respect to somebody who's transgender.
Right.
There's no science to back that up. So if we order an MRI and absolutely everybody who feels are transgender, that's kind of unacceptable.
If it's not an MRI, then what is it?
I can't comment on what Dr. Fetter has said, but we know that there's been no studies that tell us if you get an MRI, that's going to tell you that you're transgender.
How do you know it exists?
By talking to our patients and being supportive of them. And
yes, but people make all kinds of claims like this, especially like mentally ill people. You know, there are entire societies out there that are dedicated to the support of alien abductees, but that doesn't mean that we accept that alien abduction is an actual thing, that's a natural phenomenon.
The main thing I think that we have to think about is nothing that we do or say is going to change how we feel.
How do you know that?
There's nothing that because I know that. He's going to feel how he feels. He's going to feel how he feels.
Right. But when people feel a certain way or think a certain way that doesn't conform with reality as we understand it through science and through what can be confirmed, whenever that perception discords with that reality, in every other case, what we do is we offer them therapy. We offer them maybe some medication, something like that. But we don't accept the delusions where somebody's perception of reality discords with what we understand about reality. We would call that a delusion, but in this case, we don't offer the counseling and the medication. We actually change the reality to conform with the perception. So why is this the exception?
So I'm just going to go back to if, and I think he is moving toward testosterone, and that's going to be his decision, and completely his decision when he wants to do it. If he did revert, your worry is that if he reverts back, what is the effect on his mental health at that point, right? So, but what will be the effect? Because you're going to be there to support him if that happens. Our main thing is that we want to support him and be there for him and be accepting of him.
Well, my main thing is that I want to prevent harm from coming to my child. So what about that harm by not doing anything, right? Well, I don't know that is. Right now? In every other medical circumstance, it's not the case that the medical intervention is necessarily considered to be the less harmful approach, because there's a risk-benefit analysis there that just doesn't support that course of action. You're pursuing a course of action that has an inherent risk associated with it.
There's also a risk of not doing anything.
Okay, well, how did you determine? Well, I mean, I haven't seen that, but I'd be happy to look at what other studies you might have. Everything that I've seen seems to be indicating that the suicide rate does not go down. I understand the seriousness of the situation. Don't get me wrong, my heart goes out to anybody who's suffering, but that doesn't mean that I'm just going to suspend disbelief in favor of an unscientific approach. I don't see any science behind any of this, and I keep asking for it, but I don't get it.
I don't think, the thing is, I don't think we're going to be able to make you satisfied.
Well, you're wrong about that, because I'm willing to change my mind. It's just that I need to see evidence.
I hear you, but we're not going to be able to give you the evidence that you want.
Because you don't have any. Is there any other medical intervention that you would pursue without evidence?
Yeah.
Like what?
Okay. I think, but I'm not going to keep going.
I'm just asking for an example.
No, I hear you.
I mean, give me the evidence. I'll change my mind.
Okay, so you're getting slightly aggressive here.
Yeah, that's because you're putting my child in danger with this recklessness.
Okay. We can go around in circles and keep going around in circles.
I'm not going in circles.
We're just trying to help.
I'm not going in circles. All I asked for was some kind of evidence.
We're not going to be able to give you that evidence. Hi, Dan.
Hi.
How are you?
Good.
So, what can we do?
Well, last time we talked, you said with revision for adolescent dysphoria. You said you were going to get them for me?
I don't have them here today.
Oh.
Didn't realize your appointment was today.
Oh, okay. So you don't have any of the things that you said you were going to get?
Okay. Is it going to help for us to talk here? Because I don't think it is.
I don't know if it will. It really depends on you.
I don't think that's the
I got the stuff that you asked.
Okay. All right.
I don't think they will.
I'm not gonna sit down and do this with you today. I'm really not.
Well, here's what it is.
I support your.
There's the Johns Hopkins one because they stopped doing the surgery. Such help should be psychiatric rather than surgical.
Okay. All right. Listen, this isn't helping.
Here's long-term follow-up transsexual persons undergoing sex reassignment surgery, cohort study in Sweden. Surgery is not sufficient to alleviate morbidity or mortality. Female to male is 41%, down from 50%. Suicide rate. That was the case that you were making, yes?
Like disappointment with it's not about research, and they couldn't finish, and there's other issues.
Standards of care.
Yeah.
You realize that we haven't discussed any of the different treatment options, and she therefore does not have informed consent, according to these standards of care.
Well, maybe you haven't discussed. I'm not.
No. Parents, it should be discussed with parents. It's right there.
Not at that. Yeah.
And she still needs to have consultation with the parents. That's what it says.
You can always let her know to the hospital if they're not happy with it.
Yeah, I know your ass is covered. I know. It's not that. It's what you're doing is unethical. And you asked me.
Listen, I'm not, again.
Yeah, I know. You have an agenda. You're saying you have an agenda.
It's not about your ass.
Yes, it is. Yes, it is. But you asked me for studies showing rates of reversion up to 90%. I brought them.
We're done. We're not.
You asked me for the Johns Hopkins, and I brought them. You asked me for the studies on brain anatomy, and I brought them.